Thank you for having me back. And I want to thank the many members of the roundtable, Mary Lou, David, George, Steve, I think a variety of others in the room. Michelle, I think were with us yesterday. And I thought that we had quite an exciting day. So very briefly, I feel a little bit like, remember, I think it was Laszlo Toth who was Father Guido Sarducci on Saturday Night Live. And one of his routines was the 5-minute university, which is, a couple years after you're out of college, the 5-minute university is what you remember, like, Spanish, como está usted, or economics, supply and demand. Well, this is what you're going to get is what I remember from yesterday. It was a very packed day. I was exhausted, but I went home and thought, oh, what is it that I can bring back in a few minutes or half hour or so and summarize what we accomplished yesterday. So let me begin by saying that this was when I was serving as one of the associate directors in the office of the director at the NIH, responsible for a small office called the Office of Behavioral and Social Sciences Research. And our job at OBSSR, as it's called, is to stimulate behavioral and social sciences research and public health research across these 27 independent institutes and centers at the NIH. And this is actually quite a challenging job, partly because OBSSR doesn't have much of a budget. So although in dollars it sounds like a reasonable number, but if you look at it as a proportion of the NIH budget, I'd like to say it's 1/10 of 1%, but it's not actually. It's about 8/100ths of 1% of the NIH budget is devoted to this effort. So the way you do this and advance your agenda is that you go out and make friends and partnerships. And so part of what we were trying to accomplish in this workshop was to convene a heterogeneous group of experts representing a wide range of fields like education, economics, sociology, demography, epidemiology, psychology, and then a bunch of medical subspecialties like family medicine, general internal medicine, pediatrics, preventive medicine, psychiatry, and so forth. And we did want to get people in the room to focus some attention on this issue of education and educational attainment and life expectancy. And this is just to go back to I've been at AHRQ for 2 weeks, so way back when I was at NIH, in May, I was surprised in my years at NIH how common it was for me to introduce people to one another within the NIH who were working on the same problem but had never met each other because they were in these different institutes. So again, the challenge was always bringing people together from different institutes, in this case, to get outside of our NIH institutes into other organizations. So the second goal that we had was to identify gaps in knowledge, and the third was to stimulate interest by funding agencies in developing a robust new research agenda around this issue of education and life expectancy. So what I'm going to do is briefly tell you what some of the highlights, and I'm going to try to race through this because so many of you were here with us yesterday, and I hope you can participate and fill in the things either that I missed or that I got wrong, and I think it's likely that I will get several of them incorrect. So here we go. So the first talk of the day, I do remember because it was me. And so I have been trying to make the argument that the NIH has as its mission science in pursuit of fundamental knowledge about the nature and behavior of living systems. But the second clause is to apply that knowledge to enhance health, lengthen life, and reduce illness and disability. And I believe that this second clause is quite similar to the objectives of the roundtable. So what we're attempting to do is apply knowledge to get people to live longer, healthier lives. And one of the ways I like to introduce this topic is this. And I know that there will be quibbles about in the nature of the data and whether or not it comes from RCTs and so forth, but just bear with me because I want to make the argument that educational attainment's impact on life expectancy is not trivial. So if we look at a lot of things that we debate about, certainly now that I'm at AHRQ, there's a debate about whether or not you should have a pap smear every third year as opposed to every year. And actually people get very enthused about this. But if you look at the difference in quality adjusted life expectancy, it could be a day or a few days, but certainly not much more than that. Or if you look at mammography, if we look at least all-cause mortality, maybe it provides a benefit of a month, and that debate is starting to reemerge. I think the task force is going to look at that again this year. Normal cholesterol versus LDL cholesterol is greater than 160. These are untreated people from the Whitehall study. Maybe 6 months of life, quality adjusted life expectancy. Systolic blood pressure greater than 140 versus less than 120 could be 8 months in quality adjusted life expectancy. Smoking cigarettes is probably about 6 years, depending on the analysis. But when we look at this literature on educational attainment and life expectancy, and we look at the difference in life expectancy between those who have an advanced degree versus those with less than a high school education, some of these analyses show it's 12 years. So we feel that this is just way too big to ignore. And people argue and they say, well, it's not an RCT. You need RCTs to identify subtle differences. This is not a subtle difference. Another way to look at it, one of the speakers yesterday was Sandra Galeo, who's an epidemiologist at Chair of Epidemiology at Columbia. And he had a paper in the American Journal of Public Health last year where he looked at the impact of various things in terms of number of lives lost. So we talk a lot about homicide, where we could be losing perhaps 30,000 lives per year, motor vehicle crashes, maybe 40,000 per year, suicide, oops. There we go. A little bit more, diabetes, up to say 60 to 70,000 cases per year. Alzheimer's disease, big debate about how many cases, but let's call it 80,000 cases per year. Stroke, maybe 125,000 deaths that are premature per year. But if we look at the impact of having less than a high school education, according to Sandro, it's about 240,000 lives per year that are lost because of this differential. Now, we don't know if putting those people in school and so forth will extend life expectancy, but the argument that I tried to make in my opening comments yesterday was, if these data are right, this is an enormous impact that we just can't ignore. And I'm glad that we're going to be focusing another day of attention on it. So what happened yesterday? Well, we had a bunch of different speakers, and I'm just going to hit some of the highlights for me because there was so much and so much coming at us. But I thought that one of the most interesting papers was a presentation by Neil Halfon, really working in collaboration with Debbie Chang, who is a member of our roundtable, who's been talking about how we need to revise the healthcare system. I think very much in line with what we're doing in the roundtable. And Neil's argument goes something like this. He argues that there have been 3 eras of healthcare. By the way, this is based on Lester Breslow's book, Life in Public Health. Lester was, one smaller version. Lester was my colleague at UCLA. He died at age 97, just maybe 2 years ago. And when I first came to UCLA, he had me over to his house. He likes to make martinis and talk. And he said, when I was head of the chief health officer for the state of California, the governor called me in one day, and he said, and Earl said to me, that Earl. Anyway, so Lester was actually the head of the health department in California when Earl Warren was governor. So, I mean, pretty remarkable career. But anyway, so Neil, based largely on Lester's book, argues that there was the first era of healthcare. And this first era of healthcare was focused on acute disease and infections, the germ theory of disease, and it was pretty much an industrial model. And he argues that if you look at hospitals, hospitals look like factories because they were essentially the doctor's workshops where people with acute illnesses came in to get fixed. And so the goal was to reduce deaths. And the point of intervention was the point at which acute illness started. But he said science, and I think this is very important for us to think about, what changed things was how science moved along. And so Neil's argument is, well, science changed because epidemiologists became more active. We had the Framingham Heart Study. We realized that there were risk factors and that, in fact, we need to identify these risk factors because most of the burden on the healthcare system was not acute illness treated in hospitals, but in fact, it moved out into ambulatory care settings. So the time frames got longer, and the goal shifted from reducing deaths. Now, of course, the goal is still to reduce deaths, but also added to that was prolonging illness and disability. But he argues that, in fact, there is a new era, and this new era has to emerge because science has changed. So what's happened now is that There's an increasing focus on optimal health. We recognize the new science recognizes complexity, it recognizes life paths and so forth. And so it has to be lifespan, and that it has to move again out of just hospitals and ambulatory care settings, but it necessitates these new partnerships. And so System 1.0 looks like this, and what he called System 2.0 is the current system. I think he argues, I don't know, Debbie, he argues we're at 1.7 or something, that we're not quite to 2.0 yet. So he argues that the next generation is 3.0. It's like a new operating, it's like you've got your operating system like DOS 1.0. And the argument is that, well, we're getting close to 3.0. We've got a lot of apps, but they won't run on your computer because you're running System 2.0. So one of the arguments that Neil made, I thought very persuasively, was that if you look at these trajectories, so you can look at a current trajectory, which involves some sort of delayed development, and then you can look at an optimal trajectory. There we go. An at-risk trajectory. And the argument is that there are a bunch of factors that are pushing this curve down. And so that, that it's pushing us toward this delayed trajectory. And what we want is a different trajectory to actually to push wellness higher, and in this case, the readiness to learn. And the argument is that we have to do a variety of different things to push this back up again. And so we have to read to kids, we have to use appropriate discipline, have appropriate health services, preschool, and so forth. And this will push this curve up. And if we do that, the argument is this: we might have a low health trajectory. This is sort of health development. But what we want is we want an optimal trajectory. And so we have to engage in a variety of activities that push this current trajectory from low to optimal. And if we do that, we will delay the point in the lifespan where people become symptomatic. And if we're able to do that, and we look at the cost curve, we have the cost curve at the bottom being relatively low throughout most of life, but then spiking. So that if we're able to change these trajectories, we can push costs lower. And so his argument is that if we look at the lifespan, System 1.0 intervened when people became symptomatic at the end of life. And he described in his talk all of these resources flowing to the end of life. Where System 2.0 started intervening when there were risk factors, and he argues that System 3.0 needs to take this life course perspective. And so what we need to do is we need to take the entire life course into consideration. So we heard a lot about this yesterday, and I think one of the most interesting presentations was from Flavio Cina, who is an economist at the University of Pennsylvania, who got into the details of the relationship between reading to kids and the development of appropriate vocabulary. And he pointed to this data, or these data that people are so familiar with, that there is a big difference in vocabulary by 36 months among kids from high SES, working class, and low-income earning families. And Flavio's presentation, which I can't do justice to because I'm just going to do it in a slide, but his argument was that, in fact, this has to do with allocation of parental resources, including parental time, but also lack of information. And that this serves as a cornerstone for all sorts of other developmental things, which I think is quite crucial. And I know we'll be coming back to some of that as we go through today. I think the heart of the day was spent on this relationship, this very systematic linear relationship between educational attainment and life expectancy. And we saw a lot of graphs like this showing that, in fact, that at least in some data sets, these relationships are quite linear across the lifespan. And so, I'm sorry, across the education attainment continuum, so that even continued education beyond the high school degree continues to gain you benefit in terms of life expectancy. But what we learned is there's a lot of debate about the functional form of this, and we'll mention this in just a minute. That David Cutler's work was mentioned frequently, and David has shown how each year of education contributes to the diagnosis of lots of common diseases. So, for example, hypertension, high cholesterol, and so forth are systematically related to educational attainment. Jim House from the University of Michigan gave a very good overview of the epidemiology. I think that some of this will probably be picked up in Steve's presentation, I hope. But he argues that education is related to risk factors, and in this case, high hostility, being unmarried, never attending meetings, and social isolation, and so forth. And these are all related. The yellow bars are 0 to 11 years of education. The blue bars are 12 years of education, and then the other ones are at least some college or more. That the education is systematically related to functional limitations, contributing to not only loss in life, but loss in quality-adjusted life. Jim also argued that although we should never downplay the profound relationship between racial and ethnic group membership and life expectancy, that in fact the relationship between educational attainment and life expectancy is stronger and more systematic, and this is shown in this slide. One of the areas that got a lot of attention is whether or not these trajectories are changing over the course of time. And I think this is well summarized in this slide. I can't give you the answer because these are research questions that we need to identify in the future. But if you look at life expectancy at birth at age 20, I'm sorry, life expectancy at birth at age 25 for white females, and you look at what this looks like in 3 time periods, 1990, 2000, and 2008. Just look over at the far left for those with less than a high school education. It appears that this is a trend that's changing rather rapidly. So that just since 1990, or between 1990 and 2008, this relationship got considerably stronger. And I think that that's something that is quite disturbing and needs attention. We mentioned, I think this slide didn't work, so let me just go to this one. Some work that I've been doing with George Howard at the University of Alabama in Birmingham, where we've taken a very large cohort study designed for stroke and looked at the relationship between educational attainment and life expectancy. And this study is like a lot of others, but this particular data set has a lot of biologic variables in it. And what we find is that if you look at the crude relationship between educational attainment and life expectancy, the far left bar, very systematic. It attenuates some when you adjust for demographic variables, attenuates more when you adjust for income. If you look at all the biological risk factors that were measured in the study, and there are lots and lots and lots of them, it attenuates the relationship more, but you still see it as very strong and linear and graded. And then if you add to that behavioral variables on top of everything else, it attenuates it, but still it doesn't make it go away. So one of the big issues that was debated yesterday, particularly among the demographers, is whether or not this is a stepped relationship. That is, that you're pretty much the same until you graduate from high school. Then if you're sort of some college gets you to a different level, and then college graduate gets you to a third level. And the argument, and there's a fair amount of debate about this point, but this slide was shown by several different authors, and it suggests that in fact, that if you look across data sets, that you lose a little bit of gain a little bit of life expectancy as you go through school up to the high school graduation. But actually a lot of the action and a lot of the steepness of this occurs after high school graduation and continues with continued graduate education through the highest levels. I mean, it's really quite an interesting finding. Mark Hayward from the University of Texas got into this issue of functional forms of these relationships. And so if you look at the non-Hispanic white males and females across data sets, the functional form looks something like this, similar to that last slide that I showed. So you gain a little bit with increasing education up to high school. Then after high school, it starts to be steeper. So the more education you get beyond high school gives you an additional benefit in terms of life expectancy. But he argues that particularly for non-Hispanic black females, we don't get this relationship. At least prior to high school graduation, there seems to be none of that benefit. So it's one of the areas where we think we need additional research. So he calls this the credentialist model, that you get your high school degree, and with that credential, then you get continued benefit. One of the other very interesting presentations was from Sandro Galea from Columbia. And Sandro, and some of you may have to help me with this because it's very complicated but extremely interesting argument. And part of the argument that he makes is that it's not really educational attainment. It's really about differentials. And the argument, as I understand it, is that what we need to do is we need to determine what the impact is. So, for example, if everybody is fairly similar, the impact is less than if there is a lot of variability in attainment across a population. When there's a lot of variability in attainment across the population, according to several of the speakers yesterday, that leads to diversion into all sorts of other things, particularly in adolescent years. So, for example, if you are not doing well in school, that might divert you off into a peer group that will put you at risk for other sorts of things. So variability, according to Sandro, was the key variable. And I think, so with regard to health habits, there was a lot of discussion about this. And I came into the meeting thinking that a lot of the mediation is through health habits like smoking cigarettes, being overweight, doing vigorous activity. And Sandra pointed out that, in fact, across data sets, that the results are quite inconsistent. And so that we need to find a better explanation of this. So his argument is that it's really more educational variability that's associated with this broad range of things. Again, with bigger and by the way, he was very hesitant to use the term inequality, but acknowledged that, like Wilkinson and Pickett and others, that in fact this is, I think, quite similar to what they're describing. I think I'll just skip through this because I want to leave more time for discussion. But you know, there's just a lot of interest in interesting variables. And one of the things that Jim House and others presented is that you actually get some benefit from your spouse's educational attainment. And so in this analysis, they look at whether or not the spouse had a less than high school education, high school, some college, and college graduation. And so for those who have differentials in education, the less educated spouse can get up to about 3 years of benefit in life expectancy through association with a more educated spouse. And I just want to point out that if we go back in time, this gets into this issue that was discussed a lot yesterday, is how is this pattern changing over the course of time? And one of the studies that was mentioned was the Terman study of genius. I don't know if you're aware of this study, but that Lewis Terman, who developed the IQ test, started a study in about, I think it was 1920 or so, where he got kids who were geniuses. So all the kids had scored in the top 1 percentile of the IQ test. And then he followed them, he followed them prospectively, but many years later, a group at the University of California, Riverside got this data set, and they've been looking at what predicts life expectancy. Well, it turns out education is important for men, not for women. And the reason it's not for women is that these women, the top 1%, rarely went to college. There's very little variability in that. So anyway, I see the orange light, so I'm going to try to just skip some of this to say that there's a lot from the demographers that got into this sort of variability, where you look at on here levels of childhood adversity. I don't know if there's a pointer here, but so if you look at the impact of having some college or educational attainment in strata of childhood adversity, it's very systematic. So there's a hit for adverse childhood experiences, but within each of those strata, there's an impact of educational attainment. And this goes for kids who had poor health status as kids, as well as kids who had good health status as kids. So I think I'm just going to go ahead and skip this and just mention the last one that intrigued me. Jennifer Montez, who is from Case Western Reserve University, talked about the number of adverse experiences that people had in childhood, including academic events, which could include academic failures. And they just look at the number of these events. But what I found to be interesting is that, in fact, there is a very systematic relationship between having health conditions as adults and having these adverse experiences. We know this. I mean, this has been reported by others. But interestingly, these academic events, academic failures, are remarkably strong predictors of disease outcomes as adults. And the final one that I just wanted to mention before, I have a couple more before I wrap up, but she got into this very interesting relationship where you look at the impact of both parents having low education versus both parents having high education, and how that relates to the offspring's education. And so you can see that there, of course, is a systematic relationship. We've been talking about that between educational attainment and functional limitations later in life. So the white line is for when both parents are highly educated, lower probability of these things. And the salmon line is for both parents low educated. So it makes sense. But then she asked this question, well, what is this differential? Can you overcome the effect of your parents being less educated with more education yourself? And you can see here that what happens is that a person whose parents were less educated, who goes on to get a high school education, is about where someone with highly or better educated parents are with less than a high school education. So the argument is that it is complex and hard to overcome. So where do we go from here? What are we doing about this? Well, our argument going into this is that we just need more of these natural experiments. That was discussed some. Mitch Wong from UCLA is actually doing studies in charter schools in Los Angeles where kids are selected on a lottery basis into these schools. And we think we need more of this, and that it turns out that our partners in the U.S. Department of Education are doing all these educational intervention studies. And so it may be as simple as persuading them to add more health data to their data collection activities. We talked a lot yesterday about different mechanisms that might explain these relationships. So there's a neuroplasticity hypothesis. Gabriella Conti from University College of London made the argument that biologically everything happens within the first 1,000 days, made a very persuasive case for this. But we didn't quite, I don't think everybody quite agrees that this is the whole story, although it's a very important part of the story. Now, there's a personality hypothesis that came up frequently. People argue that traits like being conscientious help explain this, so that perhaps the selection is that conscientious kids are more likely to complete school, and that they are more likely to brush their teeth and adhere to their medications and so forth. And then there is this habits hypothesis, which I got to say I went into the day thinking there was a lot to it, and I was a little bit less persuaded at the end of the day after hearing the discussion. So where are we going? Well, our goal all along in NIH was to build these partnerships and to persuade the different NIH institutes with new partners to put more money into data sets like Project Talent. Project Talent is a longitudinal study that was started, well, a study that the Department of Education started in 1960, where they tested, actually gave 100 tests of various sorts to 400,000 kids. And then they followed about 100,000 for 20 years, and then they haven't been followed since then. And so that that this effort would involve getting death certificates, figuring out what's happened to those people who are now in their 70s. And then we got into linking, how you link data. The state of Florida, for example, has this cradle-to-grave database in education that doesn't connect to anything else and has tough access. So how did we do with our objectives? Well, we wanted to convene a heterogeneous group of experts representing all these different fields. Actually, I think we did well on this. We put a lot of effort into making sure that the gerontologist was the critic for the pediatrician. And so we got a lot of people there. We got people from different disciplines who didn't necessarily know each other. So I thought we did well on that. Identifying gaps in knowledge, I would say C+, could be actually C-. That I was personally a little bit disappointed, largely because we made an error when we planned the meeting. We were so excited about bringing these people in. We did a relatively poor job of time control. I see my red lights blinking also. Relatively poor job of ending the discussions in time to have greater audience participation. So I was disappointed in that piece. And finally, stimulating interest in funding agencies, question mark, question mark. We are going to continue working on this, although I'm at a different agency. I've made a commitment to the NIH that I'm going to stick with this and do the best we can to continue to convene people to talk about this issue. So that's what I learned yesterday, or didn't learn. How's that?
Bob. Thank you, Bob. And okay, the red light stopped flashing for me, so that's good. So it's now time for our keynote presentation. So I'm very pleased to introduce Dr. Stephen Wolf, who would be presenting on the evidence base between the relationships between education and health. And you can see his bio in your meeting materials also. I'll give you some brief highlights. Stephen is professor in the Department of Family Medicine and Population Health at Virginia Commonwealth University. And he's also the director for their Center on Society and Health, which has a new initiative on education and health. And also notable to today's conversation is the fact that Steve chaired a National Research Council IOM committee that authored the report, U.S. Health in International Perspective, Poorer Lives and Shorter Health. So welcome, Steve.